Good evening, sir. You are muted, sir. Muted.
Now not muted at the moment. Am I audible now? No?
Yeah, yeah. So can we start, sir?
Sure. Why not?
So today is a special occasion, sir. Now we are in the 10th issue of our OcuHealth Escapes, and this is the monthly update on the environmental and occupational health issues, local, regional, and global. And this is a very good initiative by the AUSD and the members of this ENOC initiatives, and this OcuHealth Escapes it brings to our kind attention the latest developments which have been there in the recent last month, what the activities were there nationally, internationally. So that is being deliberated by Dr. Rajiv Kumar Jain. Dr. Rajiv Kumar Jain is Senior Vice President of Association of Environmental and Occupational Health, Delhi, and he is also member of Management Committee of the Scientific Committee on Epidemiology in Occupational Health, that is EPICO, and he is a senior consultant in Indian Railways with 40 years of experience in health and hospital administration, and fellow awardee of Indian Public Health Association and Association of Environmental and Occupational Health, Delhi also. And he has published and presented more than 145 papers in national, international conferences, journals, and books. And he has received fellowships, scholarships by WHO, ILO, National Institute of Health, then International Clinical Epidemiology Network. So, sir, you have been a great resource person for every one of us, and we would like to request you to start this OcuHealth Escape, which is being live telecasted on our YouTube channel, ENOC DigiConnect webinar.
Thank you, Dr. Sandeep, for the nice words that you spoke. I don't know how much I deserve them, but all the same, we are together in this journey of actually making people aware as to what has been the developments at the local, regional, and global level in the field of occupational and environmental medicine during the past 1 month. And we keep it archived over the YouTube, as you said, DigiConnect webinar platform. And I'm noticing the increasing number of people are watching the recordings as well. So we continue to create a resource for future, as well as any future occupational health practitioner can look back and revise what has been happening. So today's webinar, we shall discuss 4 key areas. One and most important is the global air quality guidelines have been released on 22nd of this month by the World Health Organization. We shall have a look at them. Second, we shall also have a relook at the WHO ILO guidelines, which have been issued recently regarding the damage that long working hours cause and other risk factors cause for the health of the workers and how much contribution they make. In addition, we shall have a relook at the eShram portal as to what has been the progress. Last month, we had introduced the eShram portal, and we noticed that this is designed for long-term engagement of the migrant workers and to provide them social security. We shall have a look as to what has been the progress during the past 1 month. In addition, we shall also have a look at what the CEOs are thinking about as to what is the future of occupational medicine in the next 10 years in the world. So these will be the key key areas that we shall visit. In addition, we shall have a look as to what has happened and in the field of occupational health medicine, in addition to the 4 areas that I've mentioned just now. So let's have the presentation first, and then we will see how we go along. And if anybody wants to ask any question, he is free to ask any question. We shall discuss all these aspects. This OcuHealthscapes is, you must have seen it in 3 colors. Occupational health is health in the center, and scapes. So we sweep the landscape with occupational health, and we connect through hashtag over the social media. Next slide, please. New WHO Global Air Quality Guidelines, which aim to save millions of lives from air pollution. As you know, air pollution is one of the biggest environmental threats to human health, alongside climate change. On 22nd of September 2021, after 16 long years, because the last WHO Global Air Quality Guidelines was issued in the year 2005. So after 16 years, the World Health Organization on 22nd September 2021 released or launched a new World Health Organization Global Air Quality Guidelines. They provide clear evidence of the damage air pollution inflicts on human health at even lower concentrations than previously understood. The guidelines recommend new air quality levels to protect the health of populations by reducing levels of key air pollutants, some of which also contribute to climate change. Since WHO's last 2005 global update, there has been a marked increase of evidence that shows how air pollution affects different aspects of health. For that reason, and after a systematic review of the accumulated evidence, WHO has adjusted almost all the air quality guidelines levels downwards, warning that exceeding the new air quality guidelines levels is associated with a significant risk to health. At the same time, however, adhering to them could save millions of lives. Every year, exposure to air pollution is estimated to cause 7 million premature deaths and result in the loss of millions more healthy years of life. In children, this could include reduced lung growth and function, respiratory infections, and aggravated asthma. In adults, ischemic heart disease and stroke are the most common causes of premature death attributable to outdoor air pollution. And evidence is also emerging of other effects such as diabetes and neurodegenerative conditions. This puts the burden of disease attributable to air pollution on a par with other major global health risks such as unhealthy diet and tobacco smoking. So now one could understand the enormity of the challenge to human health of children as well as adults. We shall now have a look and we shall watch a video where the DG of the WHO, Dr. Tedros and Dr. Maria will introduce these new guidelines. So let's watch it, not this video. Yes, this is the video.
Hand the floor to Dr. Tedros for his opening remarks. Dr. Tedros, you have the floor.
Because of air pollution, the simple act of breathing contributes to 7 million deaths a year. Almost everyone around the world is exposed to unhealthy levels of air pollution. Inhaling dirty air increases the risk of respiratory diseases like pneumonia, asthma, and chronic obstructive pulmonary disease, and increases the risk of severe COVID-19. It's also a major cause of other non-communicable diseases like ischemic heart disease, stroke, and cancers. Air pollution is a health threat in all countries, but especially for vulnerable groups in low and middle-income countries with poor air quality due to urbanization and rapid economic development, and air pollution in the home caused by cooking, heating, and lighting.
Historical event, the launch of our WHO Global Air Quality Guidelines.
Today, we're proud to launch the updated WHO Global Air Quality Guidelines, which provide clear evidence of the damage air pollution inflicts on human health. Since the last update in 2005, a substantial new body of evidence has accumulated, further demonstrating the degree to which air pollution affects all parts of the body, from the brain to a growing baby in a mother's womb, at even lower concentrations than previously observed. That's why these new guidelines include low recommended levels for pollutants, including particulate matter, nitrogen dioxide, sulfur dioxide, and ozone. These new guidelines will have major implications for public health. They provide a practical tool for improving air quality around the world and a robust evidence base for developing national and local air quality standards.
Dr. Hans Kluger, the WHO Regional Director for Europe.
The last time WHO published air quality guidelines was in 2006. In the 15 years since, there has been a substantial increase in evidence of how and to what degree air pollution affects different aspects of human health. For that reason, and after a thorough systematic review of this accumulated evidence, almost all the updated guidelines levels are now lower than they were 15 years ago. We know that for many countries, this places the bar even higher than before. However, these guidelines also provide interim targets to support a stepwise progress towards their achievement, and thus a gradual yet measurable public health benefit.
The guideline development group responsible for reviewing the evidence and developing this new.
The next step is now for policymakers around the world to use these guidelines to develop evidence-informed policies to decrease the unacceptable health burden that results from air pollution exposure.
What sort of action should leaders be taking at COP26?
WHO is preparing a very big report to be presented at the COP26 to strengthen the importance of having more action on mitigating the causes of climate change, because those mitigation of the, interventions will have enormous health benefits. And most of the health benefits of mitigating the causes of climate change will come in the sense that they will reduce the levels of air pollution, and by doing so, you can imagine the incredible number of lives we will save.
Thank you very much, Dr. Nera. I'm just checking with Euro if they wish to come in.
If we want to reduce the levels of air pollution globally, one of the key questions is related to the energy sector. So we need to, as the call by launching today this updated air quality guideline is very much about accelerating this healthy energy transition that is very much needed, moving to renewable and clean sources of energy, because this will have a very positive impact on reducing the greenhouse gases emissions and therefore tackling the causes of climate change and reducing air pollution. And both are critical pillars of our health.
So friends, you've now heard the WHO Director General, the Regional Director for the European region. The European region, by the way, was responsible for doing all the groundwork for preparing these global air quality guidelines. And you also heard the Director, Environment, Health in the World Health Organization, Dr. Maria Naira. So this is the cover page on the right side, the WHO Global Air Quality Guidelines, and the symbolic picture on the left, a child in front of a factory in a developing country, in low and middle income countries, exposed to foul air and of course all the ill effects of poor air quality. Next slide, please. WHO air quality guidelines levels are lower than 15 years ago. Let's see what is the level. In yellow are the 2005 long-term air quality guideline levels, and in green are the 2021 long-term air quality guideline levels. Fine particulate matter is now 5 microgram per cubic millimeter. Particulate matter PM10 is 15 microgram per cubic millimeter. Ozone in peak season is now 60 microgram per cubic millimeter. Nitrogen dioxide is now 10 microgram per cubic meter. These are the WHO air quality guidelines set goals to protect millions of lives from air pollution. So look at the change which has been brought about, substantially lower, especially for PM 2.5 and nitrogen nitrous oxide. Next slide, please. If you look at the solutions that are available for meeting these air quality guidelines, are all feasible, practical, and one should together ensure that we invest in energy efficient power generation, we improve domestic industry and municipal waste management, we reduce agricultural waste incineration, forest fires, and certain agroforestry activities, we make greener and more compact cities with energy efficient buildings, and we provide universal access to clean, affordable fuels and technologies for cooking, heating, and lighting. And also, not to forget, we build safe and affordable public transport systems and pedestrian and cycle-friendly networks. This will ensure, I'm saying again, these WHO air quality guidelines, they set goals to protect millions of lives from air pollution. We must not forget this. Next slide. Reducing air pollution and mitigating climate change together help to protect our health. That is the linkage between reducing climate change and reducing air pollution. These are the mitigating emission level strategies. And health will thereby be protected. Next slide, please. This I've already talked to you. Carbon monoxide is now 4 milligram per cubic meter. Sulfur dioxide is 40 microgram per cubic meter. Nitrogen dioxide is 25 microgram. Ozone in 8-hour time period is 100 microgram per cubic meter, which was already there. Particulate matter PM10 is 45 microgram per cubic meter, which is lower than what we had in 2005. And fine particulate matter is now 15 microgram per cubic meter, which is substantially lower than the 2005 standard. These are the goals. These are the new WHO air quality guidelines goals. Next slide. The WHO air quality guidelines, they provide various good practice statements for sand and dust storms, black elemental carbon, and ultrafine particles. Next slide, please. Air pollution is a silent killer. Every year, around 7 million deaths are due to exposure from both outdoor and household air pollution. Air pollution is a major environmental risk to health. By reducing air pollution levels, countries can reduce stroke, heart disease, lung cancer, chronic obstructive pulmonary disease, pneumonia, and asthma. The regional estimates, according to WHO regional groupings, in Southeast Asia, more than 2 million. In Western Pacific region, more than 2 million. In 1 million in African region, 500,000 in deaths in Eastern Mediterranean region, 500,000 deaths in the European region, and more than 300,000 deaths in the region of the Americas. So we in Southeast Asia will be the major beneficiaries if we focus our attention on air pollution control, because we will be able to prevent more than 2 million deaths. Leave aside the disability adjusted life years that we shall gain out of improvement in air pollution. Next slide, please. The WHO air quality guidelines set goals to reduce air pollution. They set out to achieve this by, number one, interim targets help countries to continuously improve air quality. And number two, recommending AQG levels to protect people from air pollution. Current levels are higher, interim targets are lower, and recommended AQG levels are still lower. So there is a roadmap. It is not that one can do or one can reach the destination in one day. It takes years and concerted efforts to reach that level. Next slide, please. Sources of air pollution are a global challenge we must tackle together. Like sources are industry and energy supply, dust, agricultural practices, household energy, waste management, and transport. All these are sources. So this is not a single source which is causing air pollution. Next slide, please. WHO has redrawn the lines in the battle against pollution. As I told you, 80% of deaths related to PM 2.5 could be avoided if updated guidelines are followed according to WHO. Why are the old standards changed? Because the last time WHO updated the AQGs was in 2005. Since then, volumes of new evidence have emerged to show how air pollution affects different aspects of health. More than 500 scientific papers were identified for systematic review and synthesized by experts to get the most up-to-date evidence of the impact of pollution on the human body. In the center, you are seeing the light blue 2005 and the dark blue 2021. And in the red, what you see are the Indian standards. And look at the difference. Even at the 2005 level, Indian standard today are much, much higher. And we have to now, global standards have still been lowered. So the gap between what Indian standard is and what we have to achieve as per WHO air quality guidelines of 2021 has further widened. Like for example, for PM 2.5, now it is 5, Indian standard is 40, while in 2005 standard was 10. We have yet to achieve that level. For PM 10, it is global was earlier 25, Indian standard today is 60. And globally now the changed standard is 15. So the gap has further widened. The 24-hour PM 2.2 for the PM 10 is now at the moment it is now 45, while Indian standard is 100. Similar is the status with ozone, nitrogen dioxide, sulfur dioxide, and carbon monoxide. Fortunately, we have the Indian standard and the global standard 2021 same. Same is the situation with ozone. Next slide. Let's see where Delhi stands in pollution fight. Experts said Indian cities may find it difficult to achieve new WHO standards. PM 2.5 is hazardous. PM 2.5 is defined as ambient airborne particulates that measure up to 2.5 microns in size. These include a range of chemical makeups and come from a range of human-made sources, including fossil fuel, powered motor vehicles, power generation, industrial activity, agriculture, and biomass burning. The microscopic size PM2.5 allows these particles to enter the bloodstream upon inhalation, potentially causing far-reaching health effects. PM2.5 exposure has also been associated with low birth weight, increased acute respiratory infections, and stroke. Annual WHO PM2.5 target is 5 microgram per cubic meter. Delhi's PM2.5 levels last year, you can see in November, December, it reached a level of 157.3. Imagine, and the average 2.5 in 2020 was 84.1. Imagine the journey that we have to travel. Let's look at the most polluted cities in the world. It is Bhutan in China with average 2.5 levels in 2020 with 110, Ghaziabad 106, Bulandshahr 98, Bisrak was 96, Bhiwadi 95.5, Noida 94.3, Greater Noida 89.5, Kanpur 89.1, Lucknow 86.2, and Delhi 84.1. Imagine where we are living, how much polluted the world, in the world. We are living in an area which is the most polluted area in the world. Next slide, please. The capital falls well short of the targets. Delhi has not had any good air days this year, according to the new standards. Based on average of 34 or 40 stations in Delhi with consistent PM2.5 data since 2019, you find now WHO with WHO target 2021, days when PM2.5 targets were met were only 2 in 2019, only 3 in 2020, and in 21, 0. And days when PM10 targets were met were 4 in 2019, in 2020, 16, and in 2021, only 6 days. So imagine the challenge and further challenge we have to meet now on a war footing. Next slide. Now let's go deeper and understand the science of these global air quality guidelines. The updated WHO Global Air Quality Guidelines, they provide recommendations on air quality guideline levels as well as interim targets for 6 key air pollutants. 6 key air pollutants. They also offer qualitative statements on good practices for the management of certain types of particulate matter. For example, black carbon and elemental carbon, ultrafine particles, and particles originating from sand and dust storms, for which there is insufficient quantitative evidence to derive AQG levels. Based on the extensive scientific evidence currently available, the guidelines identify the levels of air quality necessary to protect public health worldwide. The AQGs also serve as a reference for assessing if and by how much the exposure of a population exceeds levels at which it might cause health concerns. They cover some of the most monitored pollutants critical for health, for which evidence on health effects from exposure has advanced the most in the past 15 years. The guidelines focus on so-called classical pollutants, particulate matter, PM2.5 and PM10, ozone, nitrogen dioxide, sulfur dioxide, and carbon monoxide. When action is taken to reduce these classical pollutants, it also has an impact on other pollutants. Guideline levels for specified pollutants can be used as an evidence-informed reference to help decision makers in setting legally binding standards and goals for air quality management at international, national, and local levels. They're also a practical instrument with which to design effective measures to achieve pollutant emission and concentration reductions, and therefore to protect human health. WHO periodically issues these health-based AQGs to assist governments and civil society in reducing human exposure to air pollution and its adverse effects. Next slide. Second question is, what is new in these guidelines? Since the last 2005 global update, there has been a marked increase in the quality and quantity of evidence that shows how air pollution affects different aspects of health. For that reason, and after a systematic review of the accumulated evidence, several of the updated AQG values are now lower than 15 years ago. There are also now clearer insights about sources of emissions and the contribution of air pollutants to the global burden of disease. The recommended 2021 AQG levels compared to 2005 air quality guidelines. Microgram is in and 99 percentile, that is 3-4 exceedance day per year, and average of daily maximum 8-hour mean ozone concentration in the 6 consecutive months, with the highest 6-month running average ozone concentration. Annual and peak season is long-term exposure, while 24-hour and 8-hour is short-term exposure. Compared to previous WHO guidelines, the new AQGs use new methods for evidence synthesis and guideline development. They reinforce evidence on health effects. They also provide higher certainty in the evidence of health effects occurring at lower levels than previously understood. They offer additional AQG levels, such as for peak season ozone and 24-hour nitrogen dioxide and carbon monoxide, as well as some new interim targets. They also offer new good practice statements on the management of certain types of particulate matter, that is black carbon, elemental carbon, ultrafine particles, and particles originating from sand and dust storms. Next, please. What is air pollution and where are these pollutants found in daily life? That would be the next question. Air pollution is the contamination of air we breathe, indoors or outdoors, by any chemical, physical, or biological agent that is potentially threatening to human and ecosystem health. The pollutants with the most robust evidence for public health concern include particulate matter, ozone, nitrogen dioxide, sulfur dioxide, and carbon monoxide. The health risks associated with PM smaller than or equal to 2.5 micron in diameter are of particular public health relevance. PM 2.5 and PM 10 are capable of penetrating deep into the lungs, and PM 2.5 can even enter the bloodstream, primarily resulting in cardiovascular and respiratory impacts. In 2013, outdoor air pollution and PM were classified as carcinogenic by WHO's International Agency for Research on Cancer, that is IARC. Air pollution originates from numerous sources of emission, both natural and anthropogenic, that is resulting from human activity. The main sources of anthropogenic air pollution can vary geographically, but include the energy sector, the transport sector, domestic cooking and heating, waste dump sites, and industrial activities and agriculture. The process of combustion is the greatest contributor to air pollution. In particular, the inefficient combustion of fossil fuels and biomass to generate energy. In indoor environments, the use of solid fuels and kerosene in unvented heating and cooking stoves, tobacco combustion, and combustion of for other purposes such as cultural or religious practices are important as well. Next slide. How were the recommended AQG levels determined? The development of WHO guidelines adheres to a rigorous process of reviewing and re-evaluating the evidence and involves several groups of experts with well-defined roles. A guideline development group defines the scope and key questions of the guidelines, then develops the recommendations based on the distilled evidence provided by the systematic review team. In addition, an external review group provides valuable comments, while the WHO steering group, composed of the WHO staff from all regions, oversees the implementation of the project. For the AQGs, more than 500 papers were identified for systematic review and synthesized to get the most up-to-date evidence for establishing the new AQG levels. These guidelines do not include recommendations about any kind of multiple exposures. In everyday life, people are often exposed to a mixture of air pollutants at the same time. WHO acknowledges the need to develop comprehensive models to quantify the effects of multiple exposures on human health. However, as the main body of evidence on air quality and health still focuses on the impact of single air pollutants on health outcomes, the current guideline provides recommendations for each air pollutant individually. Next slide. Why are the AQGs so important for protecting health? The burden of disease associated with both ambient and household air pollution exposure is large and growing. This is partly due to increases in the exposures in low and middle income countries, but in part also due to the rapidly increasing prevalence of non-communicable diseases worldwide as a result of population aging and lifestyle changes. Air pollution especially increases morbidity and mortality from the non-communicable cardiovascular and respiratory diseases that are the major causes of global mortality. It also increases the disease burden from low respiratory tract infections and increases preterm birth and other causes of death in children and infants, which remain a major cause of the disease burden in low and middle income countries. WHO estimates show that around 7 million premature deaths, mainly from non-communicable diseases, are attributable to the joint effects of ambient and household air pollution. Global assessments of ambient air pollution alone suggest hundreds of millions of healthy years of life lost, with the greatest attributable disease burden seen in low and middle income countries. Although the air quality has improved gradually in high income countries, pollutant concentrations still exceed the 2005 WHO AQGs for several pollutants in many areas. More than 90% of the global population in 2019 lived in areas where concentration exceeded the 2005 WHO air quality guideline for long-term exposure to PM2.5. Air quality has generally deteriorated in most low and middle income countries because of large-scale urbanization and economic development that is largely relied on the inefficient combustion of fossil fuels like coal, as well as inefficient residential fuel use and industry. However, disparities in air pollution exposure are increasing worldwide, particularly as low and middle income countries are experiencing growing levels of air pollution. Next slide. How is the burden of poor air quality distributed globally? The exposure to air pollutants is heavily dependent on their ambient concentration. For example, ambient PM2.5 concentration varies substantially between and within regions of the world. Importantly, more than 90% of the global population in 2019 lived in areas where concentration exceeds the 2005 WHO AQG levels of 10 microgram per cubic meter. And with the 2021 AQG level being lower, there will subsequently be an increase in the attributable health burden in all countries in 2019. Annual population weighted PM2.5 concentration were highest in the WHO Southeast Asia region and then in the Eastern Mediterranean region. Remember, India is in the WHO Southeast Asia region. Elevated concentrations were also observed in some Western African countries, largely due to the impact of Saharan dust. Wind-blown desert dust contributes to sometimes very high exposures to particles larger than 10 micrometer. This is a prominent issue in many arid areas in the Middle East, Northern Africa, the Gobi Desert, and elsewhere. Many of the countries with the lowest PM2.5 exposure levels were either in the WHO region of the Americas or the European region. Trends in PM2.5 indicate a relatively stable population-weighted global mean concentration, which reflects both decreases in exposure in the European region, the Americas, and recently in some parts of the Western Pacific region, and increases elsewhere. Imagine when the rich nations are showing decrease, the poorer nations are showing deterioration in PM2.5. Next slide, please. How can these guidelines be used? That's the most important question. The AQGs provide robust evidence-informed guidance to protect public health from air pollution, whereas guidelines are not legally binding recommendations. They can be used as an evidence-informed reference tool to help decision makers in setting legally binding standards and goals for air quality management at international, national, and local level. Academic researchers and national and local authorities working in the broad field of air pollution may also find them useful for planning and impact assessment. And they may stimulate further research and monitoring. They can also be used as an advocacy tool for protecting public health from air pollution, for example, by civil society and the academic world. And that's what we are doing today. The Association of Environmental and Occupational Health, Delhi, is leaving no stone unturned in advocating, protecting public health. And we must keep this pace going so that we build a volume and effective efforts are taken on the ground to protect public health through air quality management and thereby control non-communicable diseases. Next slide, please. What is the difference between the AQG levels, interim targets, and good practice statements? The AQG levels provide evidence-informed quantitative recommendations based on systematic review of the evidence of adverse health effects, including an indication of the shape of the concentration response function for PM2.5, PM10, nitrogen dioxide, ozone, sulfur dioxide, and carbon monoxide for relevant averaging times and in relation to critical health outcomes. Interim targets, they serve to guide reduction efforts towards the ultimate and timely achievement of the AQG levels. Meeting the interim targets may have a notable benefit for health, especially in those regions where exposures far exceed the interim targets. Good practice statements help to manage certain types of particulate matter, that is black carbon, elemental carbon, ultrafine particles, and particles originating from sand and dust clouds. When numerical AQG levels cannot be established in the absence of clear quantitative evidence on independent health effects from these pollutants. Next slide, please. How many lives could be saved or improved if countries achieve the new AQG levels? Achieving the recommended AQG levels will deliver substantial health benefits globally. WHO has performed a rapid scenario analysis to assess the health gains attributable to improved annual ambient particulate matter concentration. If the AQG levels were achieved, and around 80% of deaths attributable to PM2.5 exposure in the world could be avoided if countries attain the annual AQG levels for PM2.5. Reaching the interim targets also offers substantial benefits for health. For example, attainment of interim target 4 for PM2.5, that is the same level as the AQG from 2005, would result in a nearly 48% decrease in total deaths attributed to PM2.5 exposure, and the highest impact would be observed in the Southeast Asia region, where India is, and the Africa regions, and 57% and 60% reduction will happen in Southeast Asia and Africa regions respectively. Results clearly demonstrate a major reduction in the estimated burden of disease, even if other analyses may yield different estimates due to different assumptions made. The WHO scenario analysis showed that if the interim targets were achieved, the greatest benefit in terms of reduced burden of disease would be observed in countries with high PM2.5 concentration and with large population, like India. Results are significantly different for high-income countries, and in most cases, the PM2.5 ambient concentration in these areas are already below the interim targets. So this underscores the importance of the measures for controlling air pollution, especially PM2.5 in India and specifically in North India. Next slide. Is there a link between air quality and COVID-19? Yes, poor air quality is an important risk factor for both acute, for example, pneumonia, and chronic respiratory and cardiovascular diseases, such as chronic obstructive pulmonary disease or stroke. People with underlying medical conditions are thought to be at a greater risk of developing severe disease from COVID-19 infection. Thus, air pollution is most likely a contributing factor to the health burden caused by the COVID-19. During the global COVID-19 pandemic, however, there has been an important, albeit short-term reduction in concentration of air pollutants across the cities. This reduction was more prominent in the case of nitrogen oxides, a pollutant very much related to traffic, which was dramatically curtailed by lockdown measures. European data for some cities has shown a reduction of around 50%, and in some cases up to 70%. In nitrogen dioxide levels compared to pre-lockdown values. COVID-19 has been a tragedy, but at the same time, the response measures have shown how policies related to transport and the way people work, study, and consume can contribute to a better air quality, something that should be taken into consideration for the post-pandemic recovery policies that many countries are already working on. Next slide. How does reducing air pollution also support climate action? Some air pollutants, particularly black carbon, a component of particulate matter, and tropospheric ground level ozone are also short-lived climate pollutants, which are linked with both health effects and near-term warming of the planet. They persist in the atmosphere for as little as a few days or months, and their reduction has co-benefits, not just for health, but also for the climate. Almost all efforts to improve air quality can enhance climate change mitigation, and climate change mitigation efforts can in turn improve air quality. Notably, reduction or phase out of fossil and biomass fuel consumption will reduce greenhouse gas emissions as well as health relevant air pollutants. By promoting environmental sustainability hand in hand with public health protection, we can make large steps towards mitigating climate change and achieving the sustainable development goals. Next slide, please. So this is what we had to share with you about the WHO Global Air Quality Guidelines. So moving on from this topic, we take another step. If you recollect, the WHO has now created a hub for pandemic and epidemic intelligence in Berlin, Germany. To better prepare and protect the world from global disease threats, His Excellency German Federal Chancellor Dr. Angela Merkel and Dr. Tedros Adhanom Ghebreyesus, World Health Organization Director General, inaugurated the new WHO Hub for Pandemic and Epidemic Intelligence based in Berlin. The WHO Hub is part of the WHO's Health Emergencies Program and will foster enhanced collaboration of countries and partners worldwide, driving innovations to increase availability of key data, develop state-of-the-art analytic tools and predictive models for risk analysis, and link communities of practice around the world. The WHO Hub, which is receiving an initial investment of $100 million from the Federal Republic of Germany, will harness broad and diverse partnerships across many professional disciplines and the latest technology to link the data, tools, and communities of practice so that actionable data and intelligence are shared with the common good. Critically, the WHO Hub will support the work of public health experts and policymakers in all countries with the tools needed to forecast, detect, and assess epidemic and pandemic risks so they can take rapid decisions to prevent and respond to future public health emergencies. Dr. Chikwe Ihewaziri, currently Director General of the Nigeria Center for Disease Control, has been appointed to lead the WHO Hub in Berlin, Germany. And you can see the model on the right side: prediction, prevention, preparedness, response, and recovery. That cycle. And in the center, pandemic and epidemic intelligence, better data, better analytics, and better decisions. Next slide, please. This is another warning. 50 degrees centigrade in September, the world's latest heat record. A new record, 50 degrees centigrade temperature recorded at Furnace Creek, Death Valley in California on September 7, 2021. This is the latest in the year that a recording of 50 degrees centigrade was made anywhere in the world. Previous record for the latest day 50 degrees centigrade were recorded anywhere in the world in September 6, 2002 in Jordan. So now our focus is on COP26, which will be on October 31, and that will be the global decision-making process in Paris, where the global leaders will collect and take decisions for mitigating efforts to the global heat. Europe's hottest ever summer. Europe had its warmest summer on record this year. European Union scientists said on Tuesday, the 3 warmest June-August periods have been in the last 11 years. Hotter by the year, a clear trajectory. How the annual average temperature across the world has risen compared to the pre-industrial average recorded between 1850 and 1900 is shown in the graph at the bottom. You see how the change from yellow to red has occurred over a period of 100 and 120 years. Imagine the heat effect on the earth and human beings and human health. Next slide, please. Here I am sharing with you one statement from Dr. Michael Ryan, who is Executive Director of WHO's Health Emergency Program. Despite decades of investment, COVID-19 has revealed the great gaps that exist in the world's ability to forecast, detect, assess, and respond to outbreaks that threaten people worldwide. The WHO Hub for Pandemic and Epidemic Intelligence is designed to develop the data access, analytic tools, and communities of practice to fill these very gaps, promote collaboration and sharing, and protect the world from such crises in the future. So COVID-19 has given some substantive action on the ground. Next slide. Another new development during the past 1 month has been India gets its agency for road safety. Government notifies the board at the national level. The government has notified the Constitutional National Road Safety Board, which will function as a lead agency at the national level to deal with matters relating to road safety. The notification issued by the Road Transport and Highways Ministry constituting the National Road Safety Board is aimed at putting integrated efforts in collaboration with states to reduce road crashes and improve all aspects of safety. The provision of establishing the board with experts from different fields was provisioned in the Motor Vehicles Amendment Act of 2019. Several countries across the world, including the United States, Sweden, and Australia, have lead agencies at national level. The proposal for an apex board at the national level was first mooted in 2007 in the Sundar Committee report. The panel was formed to present a note to the Empowered Committee of Secretaries for the creation of a Directorate of Road Safety and Traffic Management and required the amendment of traffic laws as required. In January 2005, the Cabinet Committee on Infrastructure, headed by then Prime Minister Manmohan Singh, had directed the Road Transport Ministry to present a note prepared by a specialized panel. Next slide. According to the notification, the board will have a chairman, members, and technical committees under experts to deal with different aspects of road safety, including vehicle engineering, data collection, and crash investigation. The board will have officials from the Road Transport Ministry and state governments who will be ex officio members. The chairman members will be appointed by the central government after recommendation by a search from selection committee under the chairmanship of the Union Road Transport Secretary. Such persons must have special knowledge of or professional experience in administration, road safety, urban planning, law, traffic management and regulation, health and advocacy, enforcement and investigation, transport engineering, insurance, automobile engineering, civil engineering, and public transport. The Sundar Committee had recommended that the broad-based selection committee comprising the Cabinet Secretary and Secretary for Road Transport and DGs of Health Services and CSIR should draw up a panel from which the appointments would be made. A broad-based selection committee and a transparent selection process are necessary to ensure that the best talent available both from within the government and the market is recruited, it has said. Next slide, please. The Transport Ministry's notification specifies that the board will have the advisory role to put recommendations and proposals for the central government, which include formulation of specific standards for road safety, traffic management, and road construction for hilly regions in the country. It can also provide technical advice and assistance to the central and state governments and local authorities on administration of road safety and traffic management. The board can also specify guidelines for establishing and operating trauma facilities and paramedical facilities for dealing with traffic-related injuries on roads. Welcoming the notification, Dr. H.S. Chhabra, who is the president of Spinal Cord Society, said the Constitutional National Road Safety Board, which will function as a lead agency at the national level to deal with matters relating to road safety, is a very welcome and long-awaited step. It is heartening that the notification came on the 6th day of the Injury Prevention Week, which was commemorated for the first time from September 1 to September 7. Experts have always demanded the need for an integrated multi-sectoral approach at center and state level with a nodal agency with appropriate authority and appropriate budget. So it is an important development for road safety and development of facilities like trauma facilities and paramedical facilities for dealing with traffic related injuries on roads and prevention of a major cause for occupational risk in the country. Let's take up another topic. Next slide. As I told you earlier, E-Shram portal has been started by Government of India. Top 16 states to register unorganized sector workers in the E-Shram portal are Bihar. Second is Odisha. 22,32,000 unorganized sector workers registered. Odisha, 21,69,000. Uttar Pradesh, 11,76,000. West Bengal, 9,42,000. Madhya Pradesh, 7,30,000. Rajasthan, 5,60,000. Punjab, 4,99,000. Assam, 4,09,000, and so on. But the major source of unorganized workers, Bihar, Odisha, Uttar Pradesh, West Bengal, Madhya Pradesh, and Rajasthan have registered a good number of unorganized workers on the E-Shram portal. Next slide, please. This is the occupation-wise registration of workers at E-Shram portal. The largest, that is agriculture, 51.2%, 17.2% are construction, 31.6% are others, 6% are domestic and household workers, 5.7% are apparel workers, automobile and transportation workers are 3.5%, and capital goods and manufacturing workers are 2.7%. Next slide. This is the facilitation of registration at E-Shram portal through various modes. In dark blue are the registration by the CSC, and light blue are the registration by self, the worker himself. So in Bihar, if you see 84% is by CSC, Maharashtra 82% by CSC, Punjab 82% by CSC, Chhattisgarh 79% by CSC, UP 72% by CSC, Haryana 70%. So imagine the facilitation is actively happening in majority of the cases because these workers are illiterate at times. They do not have sufficient computer knowledge. They do not have sufficient, they need assistance and facilitation. So this is a proof that facilitation is helping registration of unorganized sector workers in the E-Shram portal. There's a major initiative for ensuring occupational health services and social security provision to the unorganized sector workers, which constitute 92% of workers in our country. Next slide, please. As I told you earlier, we will talk about the 6 health chiefs explaining why employee well-being matters more than ever. Workforce well-being has become a business priority. There is increased awareness of its links to business performance, operational resiliency, and sustainability. Organizations are increasingly appointing an executive to their leadership to focus on employee well-being and make related investments. The World Economic Forum is launching a new cross-industry community of chief health and medical officers. 2020 was a wake-up call for employers, fueled by global events ranging from disruption of the COVID-19 pandemic and mass social movements combating systemic racism to the economic downturn and mass job losses in various sectors. Employees are reporting increased anxiety, stress, and physical ill health. Coupled with unpredictable working conditions across the globe, global workforce employee burnout is increasingly and resignations are on the rise, with the US seeing as many as 11.5 million workers resigning from their jobs between April to June of 2021. As a result, businesses are rapidly prioritizing workforce well-being by appointing chief health and chief medical officers to their boardrooms with a mandate to build a culture of health in the workplace. This is a major revolutionary step which has happened post-pandemic. Next slide, please. This is statistics of pandemic causes spike in anxiety and depression. You are seeing is yellow, red, and purple. This is the percentage of US adults showing symptoms of anxiety and or depressive disorder. Symptoms of anxiety disorder from 8.2 in January to 19, it has risen to 36.9% in December 9 to 21, 2020. Symptoms of depressive disorder from January-June 19, figure of 6.6. It has risen to 30.2 in December 9 to 21, 2020. Symptoms of anxiety or depressive disorder from 11% in January-June 19, it has risen to 42.4% in December 9 to 21. It is an evidence as to how much is the gravity of the situation. Are we prepared to tackle this? Next slide, please. Alton Dorkin, head of health in Anglo American, we made extensive use of health technologies. He said, as the global health emergency became clear last year, we acted quickly to help protect our workforce from the spread of COVID-19. Across the business, we implemented all the appropriate health, hygiene, and distancing measures to keep our people safe and well, both at our mine sites and in our corporate offices, while maintaining the security and integrity of our operations to ensure unimpeded economic activity for our supply chain and flow of essential produce to our customers. We provided extensive support for our employees and contractors throughout the various lockdown periods, ensuring that everyone was able to focus on their health and safety and those of their families. We also rolled out a global health awareness and support program called WeCare, specifically to protect the physical and mental health, well-being, and livelihoods of our employees and host communities. We made extensive use of health technologies, informatics, and analytics in our approach. For example, the reconfiguration of smart watches to help enforce social distance and help with contact tracing. Recognizing the vital role we play in so many often remote communities close to our mining operations, we engaged with our communities as well as government agencies to make sure we could continue to provide and extend a wide range of essential services and equipment, both during the pandemic and into the vital economic recovery phase. Look at the way the world is changing now due to the pandemic. Next slide, please. Richard J.L. Heron, Vice President, Health and Chief Medical Officer of BP, he said, bring clarity and consistency to measures of health and well-being commitment. Since the 1990s, environment, social, and governance, that is ESG indices, have been used to demonstrate and evaluate how companies meet a range of sustainability criteria. They are often seen as a surrogate measure of commitment to the delivery of UN Sustainable Development Goals, SDGs. The current pandemic has highlighted the critical importance organizations can play in both protecting and enhancing the health and well-being of workers, customers, and the communities of which they are a part. But what does good look like in health and well-being as viewed by the current suite of commonly used ESG indices? With multiple data providers, varied index designs, and methodologies, there is more to be done to bring clarity and consistency to measures of health and well-being commitment. We have a well-being index to identify trends, training, and support programs in place and support community health projects in many locations. But how do you compare the relative impacts of each corporate program on employee health and well-being? Which programs truly change health outcomes? How do you evaluate the sustainability of health investments? The answers to these questions are increasingly important to corporations, health leaders, to their workers, customers, and investors when they consider employment, purchasing, and investment choices. We look forward to contributing to improving what works for health and well-being in ESG indices and wise decisions that support SDG delivery. A path-breaking thought process, and this is what the change has occurred post-pandemic. Next slide. This is the model. Prosperity, planet, people, and institutions. Prosperity is through GDP, income, and wealth inequality, and social mobility, and financial resilience. On the planet side, energy mix and intensity, greenhouse gases emissions, distributional issues, impact and mitigation, and natural resilience. And the people component, human capital with education and skills, human capital with public health, and social resilience. So together, financial resilience, natural resilience, and social resilience bring the change in the institutional context. That is the model. Next slide. providing health and well-being resources that holistically target stress and work-life balance. This is what Huma Abbasi, who is the General Manager, Health and Medical, Chevron Corporation, said. Market volatility, social and political unrest, natural disasters, and organizational changes are some of the many stressors our workforce has had to endure alongside the uncertainties of the pandemic. With essential operations worldwide, much of our workforce never left the workplace, while most others have worked remotely for an unprecedented 18 months or longer. We recognized that regardless of work location, unmanaged stress can lead to physical and mental fatigue, negatively impacting health and safety. Chevron's medical, human resources, and emergency management teams partnered to provide health and well-being resources that holistically target stress and work-life balance, address personal resilience, and aid workers and their family members needing assistance. Our teams implemented health and well-being safeguards to prevent the spread of COVID-19 that included testing, hygiene, contact tracing, masking, and distancing. Encouraging vaccination was also a priority. In many locations, Chevron partnered with local governments and hospitals to make vaccines available to our workers and in some cases, their dependents. We stay committed to protecting the health and safety of our workforce, assisting those affected, and supporting our own healthcare workers on the front lines of the pandemic. This is a very positive trend. Deloitte Chief Wellbeing Officer Jane Fisher said, building a resilient workforce means investing in employee well-being. While many organizations have long recognized that well-being is important, the pandemic pushed it to the top of leadership agendas. Executives realize now more than ever that a resilient workforce is critical to an organization's success, and building a resilient workforce means investing in employee well-being. At Deloitte, we believe that well-being goes beyond just physical health. It also includes mental and emotional health, personal purpose, and financial well-being. That's why we create flexible and inclusive programs and benefits, like our well-being subsidy that can be used for purchases and services such as meditation instruction, fitness classes, massages, scuba diving, golf course range fees, and more. We also understand the programs and benefits only go so far if you don't have a culture that truly supports and encourages well-being at work. We leverage the power of our employees who have a passion for well-being, and we empower them to share knowledge and engage their teams and colleagues in well-being related activities and learning. This network, called the Well-being Wizards, spans the organization and helps drive cultural change when it matters most. Though through the day-to-day interactions on the team level, we provide our wizards and all our employees with access to resources and learning programs that can help them develop healthy behaviors around sleep, nutrition, stress management, connection, setting boundaries, and more. By supporting well-being at the organizational, team, and individual level, we can drive and sustain both human performance and human potential. Next slide, please. This is a graph which shows the health requirements that have increased most in complexity in the last 12 months. And what are the 4 top things? Number 1, 23% is infectious disease control. Second, 20% mental health support. Third, 11% business continuity. Fourth, regulatory compliance, 11%. Imagine infectious disease control and mental health support have come to the top. It was never so. And still you find wellness support at number 5, 9%, industry best practice compliance, 6%, policy changes on diversity issues like LGBT, disabilities, age, gender, 5%, data management, 4%, health component of sustainability reporting, 3%, management reporting, 3%, productivity and return on investment, 2%. Look at it at the bottom, non-communicable disease control, 1%, and others, 1%, which includes health insurance coverage for diverse group, risk management, and aging workforce, and motivation. This is a change which has occurred in health requirements over the last 1.5 years. Next slide. Marsh and McLennan Agency Chief Medical Officer Monte Maston said, a well-being dashboard that incorporates key metrics, business, health, and outcomes. In my role as Chief Medical Officer, Marsh McLennan Agency, I lead a team of physicians and nurses, well-being experts, and data analysts who consult with over 300 employers in the United States on innovative and prescriptive data-driven strategies to improve the health of their employees. Heading into 2020, behavioral health was already a huge challenge for employers. Depression, anxiety, stress, and substance use disorder were extremely prevalent in the workforce of virtually all of our employer partners. Certainly, how the COVID-19 pandemic has influenced all of our health, both physical and mental, has compounded the challenge. To help our business partners face this ongoing test, our team has provided assistance in a number of ways. We have partnered on employee communications and support for behavioral health resources, implemented a well-being dashboard that incorporates key metrics like business health outcomes that can help support the organization that moves to create a sustainable culture around the 4 pillars of well-being, that is physical, mental, social, and financial. Helped implement training in mental health first aid for executives and managers and supervisors, published white papers on the business case to invest in mental health as a competitive advantage, and finally, used data analytics to study the health and financial value of investment on programs that have been implemented. I look forward to working with the World Economic Forum Chief Health Officer community on innovative solutions to the pandemic that underlines the pandemic mental health. The mental health has become a pandemic. Next slide. PepsiCo Chief Medical Officer Antonio Tataranini said, our internal COVID-19 facts asked the doctor video series kept a pulse on what concerns were most pressing. This past year introduced a series of challenges and uncertainty as work and home life shifted dramatically. Individuals and businesses have had to make many sacrifices and learn to prioritize health and wellness. In the face of the pandemic, companies have implemented procedures to protect their workforce, products, and communities. As PepsiCo's Chief Medical Officer, I have overseen these efforts. We have provided our associates with several emotional and physical well-being resources and benefits to help them manage all the stressors that have been exacerbated due to the pandemic. One resource that we found to be valuable was our internal COVID-19 facts, Ask the Doctor. This is a video series with infectious disease specialists and other experts that help answer employee questions about the coronavirus in real time and kept a pulse on what concerns were most pressing for associates. We also introduced flexible work policies to give employees the responsibility, freedom, and support to work most effectively based on their individual needs. It is important for all businesses to establish a culture and work environment that values employee well-being, especially as we continue to navigate the future of work. This is a great change at the board level and the outlook, how sustainability is linked with the health and well-being of the employees, and the profit is relegated to the background. Next slide. Now we come to the WHO-ILO joint estimates of the work-related burden of disease and injury. We had a separate webinar on this issue. Today, in this segment of OcuHealthscapes, I will share with you findings which were not discussed in that webinar. Next slide. This is the rate difference and rate ratio of total deaths compared with global death rates of 34.3, attributable to 41 pairs of occupational risk factors and health outcome by region, 183 countries for the year 2016. It is the death rate per 1 lakh person for more than 15 years. And which is at the top? It is Southeast Asia region with India over there. Next is Western Pacific. And the third is Europe. Africa is number 4. This is the important evidence that Southeast Asia need to focus on the occupational risk factors and health outcome. Next slide. This is the ratio of death rate to global death rate, which is a long scale. Again, you find Southeast Asia is at the top. All other regions except Western Pacific are below 1.0. Next slide. This is a rate difference and rate ratio of total attributable disability adjusted life years compared with the global disability adjusted life year rate of 1635.9. And again, you find Southeast Asia, where India is situated, at the top. It is the worst affected. There is a Delhi rate per 1 lakh persons more than 15 years. Africa is number 2, and third is Western Pacific region. And the best is Americas. Next slide. This is the ratio of Delhi's rate of global Delhi rate, which is a long scale. Again, you find Southeast Asia and Africa are more than 1, and all other regions are less than 1. Next slide. This is the rate difference and rate ratio of total deaths compared with the global death rate of 34.3 for working age population, attributable to the 41 pairs of occupational risk factors and health outcome by age group in 183 countries for the year 2016. And death rate you find per 1 lakh person for more than 15 years. Highest you find is in 85 to 89 years, and then 90 to 94 and 80 to 84. But if you see the change which occurred suddenly after crossing 50 years of age, you see the global rate rising very, very fast. Next slide. This is the ratio of death rate to global death rate, and you find change occurs from negative to positive between 55 and 60 years of age. Next slide. This is the Delhi rate per 1 lakh persons for more than 15 years, and this is the rate difference and rate ratio of total Delhi's compared with the global Delhi rate of 1635.9 for working age population, attributable to the 41 pairs of occupational risk factor and health outcome by age group in 183 countries. And you find suddenly after age 50, the global rate is exceeded. Next slide, please. Same in a log scale, you find the change occurring at 50 years of age. Next, please. This is a proportion of total deaths and Delhi's by occupational risk factor in 183 countries. And you find by color, you can see the reference. Occupational exposure to asbestos is dark blue, occupational exposure to arsenic, light blue, occupational exposure to benzene, dark green, occupational exposure to beryllium, a little bit less green, occupational exposure to cadmium, and occupational exposure to chromium, all are green, and you find very little. What you see, occupational exposure, occupational noise, occupational injuries, occupational ergonomic factors are red. Exposure to long working hours is yellow, which is a prominent, most prominent is exposure to long working hours, yellow color. On the left you see. And occupational injuries are orange. Bottom right you find that color. Occupational noise is a pink color. Occupational particulate matter, gases and fumes are also red. The red on the right top, that is the color for occupational particulate matter, gases and fumes. Next slide, please. Now we come to just concluded 22nd World Congress on Safety and Health at Work 2021, which occurred fully online. Theme was prevention. It's on everybody's mind. Prevention in the connected age, global solutions to achieve safe and healthy work for all. And it was a very successful 4 days. I here share with you the speech of the WHO, the ILO Director General, Dr. Guy Ryder, on the inaugural function of this conference.
The COVID-19 crisis has had a devastating effect on the world of work, hitting the weakest and the most vulnerable hardest, and thus making an unequal world even more unequal. Its impact on occupational safety and health has also been profound. It's confirmed, sometimes in the most brutal way, the importance of having sound and resilient occupational safety and health systems that minimize risks for everybody. This requires investment in OSH infrastructure and integrating safety and health into national crisis emergency preparedness and response plans so that workers' safety and health are protected and enterprises are supported. Now, more than ever, we need to work together to achieve all of this. and the ILO is committed to support our member states in this task through a multilateral and coherent approach based on cooperation between governments and workers and employers' organizations, and based as well on social justice. This is reflected in the ILO's 2021 Global Call to Action for a Human-Centered Recovery that is inclusive, sustainable, and resilient. And it comes as well as our governing body is discussing whether or not to have safety and health at work designated as a fundamental principle and right at work. The future of work that we want is a future with protection for all, a future in which public institutions, the private sector, employers and workers and their organizations engage in collective action to achieve that still unattained goal of zero injuries, zero disease, and zero deaths at work.
So with this, I now request Dr. Sandeep Sharma to share the 5 scientific papers that were accepted for presentation at the 22nd World Congress on Safety and Health at Work, which he very successfully led as a occupational health physician at Indian Oil Corporation. Kindly share the 5 scientific papers that you presented at this World Congress on Safety and Health at Work. That's the 22nd World Congress on Safety and Health at Work. I request Dr. Sandeep Sharma to kindly brief us on these papers.
Thank you, Dr. Rajeev sir. So it was a nice OcuHealth escape session and lot of food for thought for every one of us. Regarding this 22nd World Congress on Safety and Health at Work 2021, which was recently held at Canada on virtual platform. This was a very exhaustive and a lot of learnings were there from this conference, and I submitted 5 papers, out of which 4 were accepted for poster presentation. The first one is the title, Successful Digitalization of Occupational Services in Indian Oil Corporation to Advance Safety and Health. This is as per the topics which you have discussed today, that integrating technology with occupational health is very important, and this will give us a lot of analytics and a lot of data, actionable data, especially for we occupational physicians. So we have successfully implemented this occupational health software across all our refineries, and now we are extending it to our marketing locations also. So all the data regarding the occupational health checkup, all the data regarding industrial health surveys, incident, accident data, first aid data, that is being, so once the data is over there, so we will do a lot of analytics and we can come out with some conclusions. And now it is centrally accessible by the corporate office. So no need to send any email to the respective locations for sending the data, and for them to find out the data from the hard copies and then make soft copies of it and sending it to us. So real-time HSE data capture, real-time monitoring of occupational activities, and its dependable analytics, it will help in reporting and aligning the HSE leadership. We are all moving towards Industry 4. Next topic, please. Yes, this was promoting the prevention of fatigue in Indian oil global supply chains of oil and gas sector. So this we developed these fatigue management guidelines, and they were inaugurated by our respected director HR. They were released, and now we are trying to implement them across the corporation. And this is with an aim to develop and effectively implement a effective fatigue risk mitigation strategy. And this is as per the API guidelines, American Petroleum Institute guidelines 755. And this will help. This is helping us in mitigating the fatigue, which is a cause of injury or even some major disasters also in the industry. Because we are all, we as petroleum industry, we are 24/7 industry. and we are working in shifts. We are working with the hazardous materials. So even a miss of a minuscule of a second that can cause disasters that we have seen because of some human errors or some other errors. Because of these factors in Jaipur fire, in Hazira fire. So this we have tried to address, and we are trying to implement it across the corporation. And this is the second paper. And the third paper is that is regarding to approach a building a strong OSH culture in Indian Oil. So this effort we started in 2010 when we started auditing all our refineries, bringing them in unison with the international standards, and all these things they helped us in coming to a common platform. All refineries, they came to a common platform, and that led to integration with occupational health software also. So this will ensure the safe and healthy workplaces in Indian Oil Corporation. And the last one is, which is very close to our heart, and that is the canteen hygiene index in Indian Oil Corporation. And this was basically meant to improve the hygiene and the health, physical health of our employees, because non-communicable diseases were very common. And this pilot project, 115 canteens were inspected, and we made our own guidelines, and efforts have been they have been applauded by Food Safety FSSAI also, and success. These are one of the success stories of Indian Oil Corporation. And all these presentations, they are available on my on my YouTube channel. You can visit them. You can just go through it and try to implement them in your respective organizations. You can, if you need any help from my side, I am ready to share all the good things with you all. Thank you very much. So you have to unmute yourself.
Thank you, Dr. Sandeep, for sharing the best practices in your organization and the concerted effort that you have made consistently and through persevering efforts, through your own efforts, and you've taken everybody along, the leadership and the team of Indian Oil Corporation, which is spread across the length and breadth of the country. And you have actually set a benchmark for others to emulate. Congratulations once again for presenting your scientific work in the 22nd World Congress on Safety and Health at Work 2021. Next, please. From October 25 to 28, 2021, we are having 28th International Symposium on Epidemiology in Occupational Health. It will be again fully online. It was to happen in Canada, from the workplace to the population, exposure and prevention. So 4 days, 25, 26 would be the pre-conference workshops. The media and occupational health would be on Wednesday, October 20th. There will be different timings. For Paris would be 6 p.m. to 10 p.m. and American continent 12 to 4 p.m. Again, on second day, there will be Brothers Bayes Boisterous Boot Camp, would be on October 21st. Again, this is 4 hours, 6 to 10 p.m. for European region, for American region, 12 to 4 p.m. And those videos will be available for later view as well. Next slide, please. This is the overall program for EPICO, October 25 to October 28, with keynote addresses, posters, symposia, key and concurrent sessions with work-related stress, musculoskeletal, exposure assessment, dust, fibers, and metal, breast cancer, and a whole range of topics on epidemiology, the entire occupational health, lung cancer, policy and regulation, work organization, disease surveillance, biomarkers, burden of disease, agriculture exposure, and a whole range of topics. And there'll be rapid fire session also. There'll be concurrent session, poster viewing sessions, and mid-career keynote address will be there, and keynote addresses which are presenters will be there, and symposia again will be there on the days. So next slide. Another major event is going to happen from 6 to 10 February, 33rd International Congress on Occupational Health. The two stages for a great digital experience, Melbourne, Rome, Global Digital Congress. Next slide, please. The 33rd International Congress on Occupational Health being organized by International Commission on Occupational Health and the organizing committee from Australia, sharing solutions in occupational health through and beyond the pandemic. From 6 to 10 February 2022, Melbourne, Rome, Global Digital Congress. Next slide, please. These are the key dates. Registration has already opened. Early bird offer from 15 June. Abstract submission date is now extended to 30th of September. And today is 24th of September. So you have almost a week to still submit your abstract, share your scientific work. Notification of abstract acceptance will be by 31st October, and deadline for accepted presenter to confirm participation will be on 9 November. A standard registration fees on offer from 10th November from onwards. Next slide, please. Early bird registration fees for people from low and middle income countries. For ICO members, it's 130 euros, and ICO non-member from low and middle income countries is only 180 euros till 9th of November. From 10th of November to 10th February, from ICO member from low and middle income countries will be 180 euros, and ICO non-member from low and middle income country like India will be 235 euros. So if you have to save money, whether ICO member or non-member, you need to register before 9th of November 2021. 5 days online congress. Next slide. These are the keynote and plenary speakers, and including Dr. Soumya Swaminathan, the chief scientist from WHO, and opening keynote speaker will be Sir Michael Mamo from University College, UK, who's speaking on health inequalities in the workplace. And they are celebrities and they are path-breaking scientists in occupational health who shall be delivering the plenary keynote speech. Next slide, please. These are the abstract areas in which you can submit the abstract. They will be published in the Safety and Health at Work journal, which has a very high impact factor of 2.707. The online submission abstract has already opened and it is closing on 30th of September. So take time and submit your abstracts. Next slide. So with this, we reach the end of this episode of OcuHealthscapes, the 10th episode. And next month, we again meet again on October 29, 2021. That is the last Friday, and again at 6:30 p.m. Thank you so much for your patience and patient listening. If any questions are there, we can discuss those issues.
Thank you, Dr. Raju sir. This was really a very great comprehensive session, and a lot of food for thought is given to us. If we think ourselves as advocates of occupational health, and we need to do advocacy for occupational health and public health, we should attend such sessions, because these sessions are very important, and this will tell you ki whatever our efforts are, maybe as association person or maybe as individual occupational physician or industrial physicians, our efforts are just a drop in ocean to safeguard our workers' health or safeguard the public health. Because all these efforts, I don't think many of our occupational health leaders who says that we are the senior leaders, they are at all aware of all these efforts which are going on across India, across the world, or across the local and regional levels. So I will summarize this, all the things, but still I would like any questions or comments from the panelists if they have. Yeah, Dr. Sanjay Rotito.
Yeah, good evening, sir. Actually,
Good evening.
do you think, hello?
Yes.
It was a very nice presentation. And do you think WHO should basically standardize also population density when we are looking at a clean air and reducing air pollution factor?
I feel yes, it's a nice thought because one has to prioritize in terms of population density as well. Because the risk,
Yeah.
high risk, along with population density, is compounding effect. As you had seen, the multiplicity of factors has not been studied, and that is the most difficult part of the impact assessment for even air quality or climate or NCD. And actually, unless we measure the impact of multiplicity of factors on human health, we won't be able to actually have real prioritized investment for high priority interventions.
Right.
I think your thought is very good and what studying further.
Yeah.
Thank you.
Thank you, sir.
Any other panelists? So with this, sir, actually, you have touched a lot of topics which are of very much relevance and very much importance for every one of us. Maybe if we are working in some industry or we are working as an occupational physician or a public health physician, like air pollution control is very important, and these new guidelines after 16 years, they are quite relevant, and we should advocate these implementation of these guidelines across the organizations also, and to make our management also aware of these guidelines. Then this WHO hub for pandemic and epidemic intelligence in Berlin and Germany. This is very good initiative by WHO, and because it will come out with a lot of actionable data and intelligence that will help the policy makers. Then the effect of heat danger, that is very important because of the global warming, and that needs to be taken care of. And another noteworthy effect by Government of India is the National Road Safety Board, which will integrate the efforts relating to road safety, because many people, they are working in silos in many places, but all these efforts, they need to be integrated. And what was important from the BHS point of view, because IUH, they have started this BHS project, but I do not know what is their contribution. I am National Secretary, but still we have to work more for eShram portal. If we can help people for getting registered, we can facilitate people to get registered on this eShram portal. I would advise Dr. Sanjay Rotito, if we can allocate funds to some third party for helping these workers for getting registration on this eShram portal, that will be a great BHS help, and it will be a great effort from IUH side also. And yes, the importance of doctors in the boardroom is very much now sought after thing, and this I have realized in my organization also. Now we are given a very good response to all our all the things which we tell to the management, and they are quite receptive of all the efforts, all these health related, well-being related, and we have started this employee assistance program also in Indian Oil Corporation after this COVID pandemic, to outreach our members to take care of their mental health. Then bringing clarity and consistency in the health and well-being commitment, that is also very important. And various models which we have deliberated, like Chevron model of providing healthy well-being resources that holistically target stress and work-life balance, that is also very important. And Deloitte model of building a resilient workforce, that is also very good if we can imbibe all these good things in our respective organization. And what is important is what is organizational need right now is a well-being dashboard that incorporates the key metrics. That is also very important for every one of us. And Ask the Doctor video, that also many people, many organizations, they are doing such sort of activities. But this is a new initiative, good thing for the doctors and for the employees also, so that they can easily connect with the doctors in case of need. For this, we have started this teleconsultation app in-house in our organization also. So, and regarding the event which has just concluded, that was a wonderful event. And the future events like EPICO, ICO will be there. So we need to focus on them and try to submit their the abstracts and try to get ourselves registered for these congresses, because these are the things which we as occupational physicians and public health physicians, we should know, and we should take care, and we should get something out of them, so that we can get the things implemented. Otherwise, we all will be working in silos, and we will all will be just running behind the leaders, and leaders will be doing the things as per their thinking. So we all need to solve these things, and we should go ahead, and we should attend in more numbers in OcuHealth Escapes, or if we have missed it, then we can see our Enoch DigiConnect webinar platform YouTube channel, where all our repository of all these videos is available. So that is a great resource, Dr. Rajiv Jain sir. You are a great resource person for every one of us, and we are thankful for your initiatives for this academic talks. So
thank you so much. Thank you. And I must appreciate the way you have summarized the various topics discussed. And I'm grateful for the time that the panelists and other audience have spared, or who will spare on the YouTube channel, because I'm finding now, DigiConnect platform on YouTube is gaining traction. So that's a wonderful initiative that we have thought of, keeping something for posterity. And this is an archive which is priceless. Now this would become the 91st video being uploaded. So small initiatives have borne fruit. And if one looks at the various topics that are available in occupational health and epidemiological aspects of occupational health on the Enoch DigiConnect webinar platform, amazing range of expertise, and the depth of subjects and the range of subjects is really diverse. So I would also support that people should take time in their free time. They should listen to them, if not watch. And if they can listen and watch, that will be again wonderful. Thank you so much.
thank you, sir. Thank you all the panelists and participants for attending the webinar. Thank you.
Thank you, Dr. Rajiv. Thank you, Dr. Sandeep.
Thank you, sir.
Yeah.